morning friends. Today we are going to deal with carbon dioxide. Let's get started. Carbon dioxide. Where is this carbon dioxide produced? In tissues. We know that, right? There is arteries coming from the heart, which is being oxygenated blood, with oxygenated blood. That means RBC is having oxygen in them, right? And is carried into the tissues where there is capillaries. So, and after that it is carried by vein. The blood is carried by veins and reaches the heart back into the right atrium. It's pumped out from left atrium and left ventricle. It's pumped out from left ventricle, right? Okay. So we know this thing. And we have to understand that this oxygen which is coming from the blood, which is bind with RBC, is now released here into the tissues and it is used up, and then it produces carbon dioxide by cellular metabolism. Okay, now we know that here there will be more carbon dioxide, here there will be more oxygen. Understand? Okay. And then we have to understand this carbon dioxide. How is this carbon dioxide being transported? It is transported in three formats. One is bicarbonate format. Bicarbonate. In the form of bicarbonate. What is this? HCO3 minus. 90% it is transported in the form of HCO3 minus. And the other is that hemoglobin binds with carbon dioxide. That is carbaminohemoglobin. What is this? Carbaminohemoglobin. Okay. And next format is what? Carbon dioxide is there, dissolved carbon dioxide, that gives into result of PaCO2. Okay. So there is three form. It is being found in the three form. And then first of all we have to understand that both HCO3 minus and hemoglobin carbon dioxide formation is taking place inside RBC actually. And CO2, and if CO2 is not coming inside RBC, then CO2 will be there here outside. But RBC is the place where it is, it is formed. So we know this thing. Oxygen is taken in by the tissues, and cellular metabolism is done. Carbon dioxide is produced, and then carbon dioxide comes into the blood, and there is carbon dioxide. Some carbon dioxide stays there, and some carbon dioxide comes inside the RBC. Inside RBC, what happens? Okay, that's what gives results into if carbon dioxide stays there, PaCO2 is there, dissolved carbon dioxide is there, and if carbon dioxide comes inside the RBC, formation of both these things happens. Understand? Okay. Let's see what happens there. Take RBC into consideration. There is this RBC, and inside RBC there is an important enzyme called carbonic anhydrase. Carbonic anhydrase. Very important enzyme. Fastest enzyme, right? Carbonic anhydrase. Keep it into your memory. Carbonic anhydrase, which will result into carbon dioxide comes into the RBC. Okay, this is RBC actually. Okay, don't forget. There is carbon dioxide coming inside. There is water inside. These two will bind and give with the enzyme give to result into H2CO3. And this will be in the form of H plus and HCO3 minus. It's bicarbonate ion. And this is the bicarbonate ion. This should be removed out of RBC, right? Understand? Some carbon dioxide will bind with hemoglobin. That is one thing. Another is how is HCO3 bicarbonate produced? This bicarbonate is produced inside RBC, but it is given outside the RBC. It should be moved out, because then bicarbonate do not want to be carried by RBC, because that's not how it works, right? Okay. So HCO3 should be transported out, then some negative charge is removed outside the RBC. That means their electrical neutrality is reduced. It becomes positively charged if some negative charge is being removed. So that we have to take in some other negative charge. Who is taken in? It is chlorine. Cl minus is taken inside the RBC to maintain the electrical neutrality of the RBC. Okay. So HCO3, when HCO3 is removed outside chlorine is taken inside. Where is this happening? In the tissues, right? From the tissue, when the blood is going through venous system into the heart, right? So we understand the RBC having chlorine inside will be found in the venous system, not in the arterial system, right? Because here is where carbon dioxide is produced. And when carbon dioxide is produced, only carbon dioxide will enter into the blood and will result in the formation of HCO3 minus, and therefore that will be traded with the chlorine. Now chloride shift is seen. This is chloride shift. Chloride shift will be seen in the venous system. Very easy to understand. Okay. Now H plus is there. H plus binds with hemoglobin and will result into HH plus. HH plus. Understand? So what is HH plus and HH plus is that hemoglobin binds with the globin chain of hemoglobin. See, normally we write HbO2, HbCO2. Why we write like this? Because it binds with Fe2 plus portion of the hemoglobin. But we write HSP. Why? Because hemoglobin is a friend of H plus is a friend of hemoglobin. Okay, and then if H plus is bind with hemoglobin, it binds to the globin chain. Globin chain at the end. Okay, it binds with the globin chain at the end. Okay, I hope you understand. So there is HSB and it is converted into a relaxed form by hemoglobin. Let's see, there are two effects that we have to learn. One is Bohr effect, and there is this Haldane effect. Okay, there are two effects that we have to learn. So Bohr effect is something related to oxygen dissociation curve. And Haldane effect is related to carbon dioxide dissociation curve. Okay, let's see both of this. Here we have oxygen dissociation curve, we have here PaO2 and hemoglobin percent saturation, right? Percent saturation. What is hemoglobin percent saturation? How many hemoglobin is bound with oxygen? That's what hemoglobin percent saturation is, right? Okay, and then we have PaO2 here, and we know the curve is like an S-shaped curve. Why is it S-shaped? Because it has a allosteric effect. There is a cooperativity relation between oxygen and hemoglobin. That's why there is a S-shaped curve. Okay. So if we have already discussed this, if there are friends of hemoglobin, who are these friends? H plus, CO2, and then temperature, and then 2,3 BPG. And note this point: if pH is increased, H plus is reduced. If pH is decreased, H plus is increased. So it is vice versa with the pH. Understand this? This is H plus, CO2, temperature, and 2,3 BPG, who are the friends of who? Hemoglobin. So these friends, what they say? Okay, hemoglobin, don't bind with oxygen. We are here. We are your friend. And who is oxygen? The girlfriend of hemoglobin. So when they are committed, they are in taut form. When they are single, they are in relaxed form. If anyone is single, they are in relaxed form, right? So who are promoting hemoglobin to be single? All his friends are saying, be single, don't be committed with the oxygen. Understand? So what happens? There is a shift. If this shift is happening, now more oxygen partial pressure. Pressure from oxygen should be more to reach that hemoglobin percent saturation. Because who are here? All his friends. Where is all his friends there? In the tissues, right? All his friends are present in the tissues, because in tissues carbon dioxide is produced, so there is more carbon dioxide, and there is cellular metabolism, therefore temperature is more, and there is 2,3 ppg because cellular metabolism happens and will result into 2,3 ppg, And more than that, H plus is there because carbon dioxide will produce H plus in the tissues. This happens in the tissues, right? Because only after tissues, only at the tissues who is produced, carbon dioxide is produced. And that's why it is entering into RBC and all this reaction happens. Now it's easy to understand. So all his friends are situated at where? At tissues. Understand? So there is this Bohr effect which shift the curve towards the right side. Okay? Easy to understand now. Now we are dealing with Haldane effect. What is Haldane effect? We have to consider carbon dioxide dissociation curve. What happens to carbon dioxide dissociation curve? Let's see. So let this be here. This is H plus CO2, temperature and 2-3 ppg. Okay. Now let's consider the carbon dioxide dissociation curve. Here it will be partial pressure of carbon dioxide, and here it will be hemoglobin, carbon dioxide content. That is carbaminohemoglobin content, right? That is how many hemoglobin is bound with carbon dioxide. That's it. And here the curve will be a straight line because there is no cooperativity, there is no allosteric effect or something like that between carbon dioxide and hemoglobin. Okay, now this will be a straight line. And when is this shifted? This can be shifted here, this can be shifted towards here. It's easy to guess because at tissues, these friends will be there. So one of the friend is carbon dioxide, and that friend will bind with hemoglobin. Understand? So hemoglobin will bind carbon dioxide, right? It will be more. Hemoglobin binding with carbon dioxide will be more when it's shifted towards left side. Hemoglobin, carbon dioxide. And why is it more? Why is the carbaminohemoglobin more? One of the reasons is the carbon dioxide is more there, but the main reason is that there is less oxygen. At tissues, we know there is friends of tissues and there is less girlfriend of hemoglobin. Right? There is more friend of hemoglobin and less girlfriend of hemoglobin. That is, oxygen is less. And therefore, hemoglobin binds with carbon dioxide. Okay? Therefore, it is shifted towards this side. And this is known as Haldane effect because hemoglobin binding with carbon dioxide is also dependent to oxygen. That's what Haldane effect is. And Bohr effect, hemoglobin binding with oxygen is dependent on H plus CO2, temperature to 3 ppg. That's what Bohr effect is. Now I guess you understood. Let's consider both tissue and and length. Okay. There is this tissue, there is this length. In tissue, we know there is more carbon dioxide, less oxygen. In lungs, we know there is more oxygen, less carbon dioxide. Right? Easy logic. And if there is more carbon dioxide, we know there will be higher H plus, right? More carbon dioxide, more H plus. Okay. And if there are more friends of hemoglobin, what will happen? There is this shift of curve towards the right side. This is due to Bohr effect. Oxygen dissociation curve will be shifted towards this side because of the friends. This is Bohr effect. Okay. And here, because there is carbon dioxide less, so there is less H plus also. Okay. And if the friends are less, what will happen? This shift toward left side. Okay. So that we understand. Now see the Haldane effect. What will happen to Haldane effect? Here it was PaO2 and percent saturation of hemoglobin with the oxygen, right? Okay. And here it is PaCO2 and carbaminohemoglobin content. So what will happen? This shift will be towards where? There is this tissue. At tissue it will be shifted towards this side. Okay. Because why? Because there is less oxygen. If there is less oxygen, then hemoglobin will be more bind with carbon dioxide. Easy to understand. There is less girlfriend there. And here there will be more girlfriend. At the lengths there is more girlfriend. So hemoglobin binding with carbon dioxide is less. Easy to understand. So we understood what is Haldane effect, what is Bohr effect. We understood where is chloride shift seen. Chloride shift is seen in the venous system, right? In the vein. Chloride shift. What is chloride shift? To neutralize the RBC, when HCO3 is moved out, chlorine is taken inside. Easy to understand. Now we are going to consider about carbon dioxide, effect of carbon dioxide in special situations like exercise, cerebral blood flow, high altitude, and control of respiration. Let's see into that. First, let's consider high altitude. What happens in high altitude? There is less partial pressure of oxygen. Less partial pressure of oxygen and less partial pressure of carbon dioxide in the atmosphere, right? ATM in the atmosphere. Okay, the atmosphere oxygen concentration and carbon dioxide concentration is less. Therefore, it will also result in less partial pressure in the alveoli and therefore less partial pressure in the artery. Artery also it will be less. Artery it will be less, right? But when we have hypoxia, when there is hypoxia, there is less oxygen in the blood and hypoxemia, whatever, we will have hyperventilation. We will breathe with a higher respiratory rate. Okay, we will be hyperventilating. But if there is hyperventilation, we have learned this like a lot of times that respiratory rate when it is increased or when we are hyperventilating, it will reduce the carbon dioxide. So there will be higher decrease in the arterial partial pressure of carbon dioxide. Understand? If this happens, what will happen? The H plus will be much reduced. If H plus is very much reduced, right? Because carbon dioxide produces what? H plus and HCO3 plus, HCO3 minus, right? Bicarbonic anhydrase inside the RBC. We have learned that. But if carbon dioxide is less, that means H plus is also less. If H plus is less, that means alkalosis. H plus is something that promotes acidosis. Acid, pH decreasing. But if H plus is less, then pH is more. That is respiratory alkalosis happens. What happens? Respiratory alkalosis. That is pH is higher. I hope you understand. And after 24 to 48 hours, this thing will be normalized. He is in high altitude and he is up to 24-48 hours. He will be hyperventilating. He will be reducing the carbon dioxide, so he will be having respiratory alkalosis. But after that, it will be taken. His hyperventilation will be reduced. He will be normally ventilating. So all these problems will be gone. How is this? How are we adapting to that situation? So first, kidney will there is kidney. They will excrete HCO3 minus because there is H plus and HCO3 minus. If H plus is very much reduced, if we are reducing this, then the thing that is contributing to alkalosis is also reduced. So we have to excrete this thing. How are we excreting it? By kidney. We are excreting it by kidney. Then the pH will be falling to normal. Okay. And the other mechanism is it is producing erythropoietin. Kidney is producing what? Erythropoietin. If erythropoietin is there, what is erythropoietin doing? Think this is the RBC, right? Think this is the polycythemia. A small duration of polycythemia is there. That is increased in the hematocrit and increasing in the hemoglobin concentration. For our 10 to 14 days. Okay, but then we have to also see that there may be what if oxygen hypoxia is there, what happens? Maybe chronic vasoconstriction may happen. We have learned this chronic vasoconstriction. What is chronic vasoconstriction? We have learned lungs are like AP people. If there is less oxygen, they don't provide blood vessel supply to that area who does not have enough oxygen. They are like, I'm not going to waste my perfusion, right? They are not going to waste their perfusion, and therefore, what is perfusion? The blood flow, right? So that blood flow will be constricted towards places which does not have enough oxygen. Okay, so therefore, when this is constricted, it's called as chronic vasoconstriction. When chronic vasoconstriction happens, maybe there is increase in the pulmonary hypertension, or maybe it can even result into right ventricular hypertrophy, right? You have learned this. Maybe it will also result into core pulmonary, right heart failure. So maybe because of this hypoxia can result into chronic vasoconstriction, which will increase the pulmonary hypertension. Maybe pulmonary hypertension, or maybe it will result into right ventricular hypertrophy and stuff. Okay. So we have learned there is respiratory alkalosis that is happening, and in alkalosis there is leftward shift of what? Oxygen dissociation curve. We have learned the Bohr effect, right? The H plus is reduced, the carbon dioxide is reduced. Who are reduced? The friends of hemoglobin is reduced. Therefore, the shift will be towards the left side. It will be TOD form. Hemoglobin will be more binding with oxygen. So therefore, leftward shift of the hemoglobin dissociation curve is happening because the friends are reduced. I hope you understand. And also the increased level, when RBC needs to release more oxygen, there will be increased in the production of 2,3-BPC. Okay. So the friends of both carbon dioxide and hemoglobin is reduced. The friends of hemoglobin is reduced. So now there is another friend 2,3-BPC. They will come into rescue. Like if some friends are like it's very less, what the other friend will do? They will come, right? So the 2,3-BPC will come and will help in adapting to that situation, high altitude situation. So 2,3-BPC is also contributing. 2,3-BPC. To release this oxygen and to the tissues, right? We have to release that oxygen to tissues and to help the tissues, to accommodate with the high altitude and hypoxia and stuff. Okay. So 2,3-BPC is there, erythropoietin is there, excreting of HCO3 minus by kidney to maintain the pH. Because if H plus is reduced, we have to also reduce HCO3 minus to neutralize, to maintain that pH. Okay. Now we understood that. So that's there. And now we are going to consider exercise. We have to deal with high altitude where hyperventilating because of hypoxemia can cause decrease in the carbon dioxide concentration. Now we are going to deal with exercise. So guys, let's see into exercise. Exercise. What happens in exercise? The muscles or tissues are doing more work. If they are doing more work, that is, they are doing more cellular metabolism, right? For cellular metabolism, they need energy. For that, they are taking in more oxygen. And they are excreting, they are producing more carbon dioxide. Okay. There is more carbon dioxide released and more oxygen uptake. And this carbon dioxide will be carried by veins. And then it will be taken from, the oxygen will be taken from arteries. Right? Easy to understand. Blood flow is like that. Okay. Now the thing is that here in the venous system we will have more carbon dioxide, right? And less oxygen because oxygen is taken off here. There will be more carbon dioxide in the venous system. Here the thing is that it should be having less oxygen because oxygen is taken up, right, in artery, and there should be more carbon dioxide. But the thing is that it will be normal. Both oxygen and carbon dioxide in the artery will be normal. Why? Because in the artery system, we have to understand that in the lungs give into the heart, right? And then heart is pumping like that. Okay? You should know this thing. Say it is alone, left heart alone, and we are considering left heart alone. We have it coming like this, and then we have it going like that, coming, going through aorta. I hope you are understanding. So, in the arterial system, we'll have lungs which is hyperventilating and heart which is pumping more blood. Okay, here hyperventilation is happening. Hyperventilation, and here more heart rate is happening. That is, perfusion is increased. Increased perfusion because of high heart rate. Here because of high respiratory rate. Perfusion and ventilation. Therefore, there will be more oxygen. There will be less carbon dioxide. Therefore, it will be, taken into normal level. Oxygen and carbon dioxide in the arterial system will be normal, but in the venous system, the carbon dioxide will be more and the oxygen will be less. I hope you understand. Now we have to look at, in exercise, we have to look at oxygen diffusion and perfusion. See, there is length along capillaries in the x-axis and partial pressure in the y-axis. And the graph for exercise is like that, and for rest it's like this. So at rest, when we are resting, the blood flow will be less, right? It will be normal speed. It is going like that. So to reach the same partial pressure of oxygen, it only have to travel a less distance along the length of capillaries because the flow is less. Therefore, more enough oxygen diffusion happens before it reaches very short length. But if blood flow is higher, it requires to travel through a long length of capillary to reach the same oxygen. Oxygen diffusion, the oxygen partial pressure. So therefore, in exercise, it takes more time. It takes more time than in rest, because in rest it becomes very fast, right? But anyway, at last, even after exercise or during rest, it is reaching what same partial pressure. At rest, it reaches that partial pressure fast, right? But on exercise, it takes time because there is more perfusion, and to that to match up with that oxygen partial pressure, it have to travel through a more length of capillary. Okay, I hope you understand. Now we are going to deal with cerebral blood flow. See, in cerebral blood flow, let's say there are two things that is dependent on cerebral blood flow. Now see, there is this oxygen dependency and carbon dioxide dependency, but thing is that cerebral blood flow is actually dependent on carbon dioxide. That's why we are including cerebral blood flow in the carbon dioxide chapter. Okay, let's see this thing. Normally, the range of oxygen is from here to here. Okay, there is a normal range of oxygen. This is oxygen content, and this is the cerebral blood flow. Same way, this is cerebral blood flow. This is carbon dioxide only. See, in the normal range of oxygen, there is no much difference in the cerebral blood flow. There is no difference, right? It's a straight line here. So even if we are increasing some oxygen content inside the normal range, we are keeping that normal range and we are increasing it, but still the blood flow will be same. But it's not like that in the carbon dioxide content. See, at each change in the carbon dioxide, this is the normal range, but inside the normal range itself, but if you are increasing the carbon dioxide or decreasing the carbon dioxide, there is a change, a huge change in the cerebral. So, if you are increasing the carbon dioxide, that means there is some hypoxia happening there, enough some high energy requirement is so if we are increasing the carbon dioxide, what happens? There is this there is this high energy requirement, right? So because there is more cellular metabolism happening, that results into carbon dioxide. You understood that? So if there is more carbon dioxide release, that means that place require more oxygen, or there is a requirement of more blood flow, therefore the blood flow will increase. More carbon dioxide, more blood flow. Less carbon dioxide, less blood flow. That's what happens here. But if there is enough hypoxia, when the oxygen content is very less than the normal range, that time there is this increase in the blood flow. Understood? So there is blood flow increasing at very high hypoxia. Okay. And here, if the carbon dioxide content is less, there is this vasoconstriction. And if carbon dioxide content is more, there is this vasodilation. When vasodilation happens, more blood flow. Vasoconstriction happens, less blood flow. Okay. What happens in panic attack? We have a panic. What do? We hyperventilate. We increase the ventilation. When there is hyperventilation, what we said? When there is hyperventilation, you are repeating this thing. Hyperventilation. Carbon dioxide will be very less. Because on hyperventilation, carbon dioxide will be exhaled out like a lot. So there will be very less carbon dioxide. So when there is very less carbon dioxide, that is hypocapnia. And there is hypocapnia. What will happen? We said that any small changes in the carbon dioxide will result into cerebral blood flow difference, right? Cerebral blood flow change. Okay, let's say like that. Sorry for the handwriting, but see, if there is a hypocapnia, that means decrease in the carbon dioxide, there will be vasoconstriction. The blood flow to that place will be constricted. So there will be cerebral vasoconstriction. It's very logical because in panic attacks we hyperventilate. On hyperventilation, carbon dioxide is reduced. So if carbon dioxide is reduced, the first thing it results in the change in the cerebral blood flow. So the vasoconstriction in the head will happen. Okay, it can result into CNS symptoms like dizziness. Oh God, it will be dizziness, blurred vision. We have learned high altitude. In high altitude, what will happen? There will be less carbon dioxide, less oxygen. But hypoxia happen, hyperventilation happen. Hyperventilation, this will reduce more carbon dioxide will be reduced, much reduce in the H plus, and if H plus is reduced in respiratory alkalosis. And then we learned what? We learned so then we learned exercise. On exercise, what will happen? There is this more carbon dioxide in the venous system and less oxygen. And the artery, it will be normal. Understood that? And also we understood how it is in exercise. It will be taking more length along capillaries to reach that oxygen partial pressure, while in rest it is reached in a very short length itself. Okay, that we have learned. And then we have learned about cerebral blood flow. cerebral blood flow, and panic attacks, right? Panic attack. Panic attacks, what happens, right? Okay. We have learned about panic attacks, cerebral blood flow. Carbon dioxide is the one which is contributing to that, even in the normal range. But to contribute for the oxygen, we have to reduce very much so that vasodilation happens and results into more blood flow. Okay, we understood all this. Now we are going to deal with breathing control. So we know the breathing control in the brain, it is medulla. Medulla have chemoreceptors, right? Medulla have chemoreceptors. They are the central chemoreceptors. So medulla is actually dependent on carbon dioxide concentration or partial pressure. While we have also, there is a central chemoreceptor and there is this peripheral chemoreceptor. Where is this peripheral chemoreceptor seen? In the aorta, in the aortic arch, in the carotid bodies, aortic and carotid bodies, right? So in that places, what do we have? We have peripheral chemoreceptors. So this will actually is dependent on oxygen partial pressure. So understand? So if, but as we know that central chemoreceptor is someone who have more control over respiratory rate. So if this central chemoreceptor found located in medulla is finding that carbon dioxide is high. So if carbon dioxide is high, we have to remove that carbon dioxide. What do we do? To remove carbon dioxide, we hyperventilate, right? So if there is more carbon dioxide, hyperventilation. That is increased respiratory rate. But if there is less carbon dioxide, hypoventilation, decrease in the respiratory rate. I hope you. So see, we have to consider some special situations like COPD, neuromuscular diseases, where there is hypoventilation. If there is hypoventilation due to COPD, see, consider COPD first. We have alveoli which is obstructed, respiratory tract which is obstructed, right? So if on respiratory tract being obstruction, there is air trapping inside. If there is air trapping inside, every time there is carbon dioxide retaining inside the alveoli or the respiratory tract, you see. If there is carbon dioxide retaining, there will be increase in the carbon dioxide. And that carbon dioxide will be increased for a long time. If there is a carbon dioxide increase for a long time, now central chemoreceptors are not working. They are not the one who increases the respiratory rate. Now the peripheral chemoreceptor comes into place and says, aha, what happens now? But then for COPD and NMD patients, what do? We give them oxygen. We give them 100% oxygen. But without checking the increase in the carbon dioxide, if we are giving oxygen, what happens is that they say, now oxygen is there. Peripheral chemoreceptors are looking for oxygen, right? So they say, now oxygen is there. So let's reduce the ventilation, decrease the ventilation, decrease the respiratory rate. So there will be hypoventilation even after we give what? We give oxygen. So oxygen actually masks the hypoventilation. They mask the hypoventilation and result into respiratory depression because they reduce the respiratory rate. This is a pathological condition that happens due to we giving oxygen without checking into increase in the partial pressure of carbon dioxide. So I hope you understand. It's very easy, and in the next chapter we'll be dealing with respiratory pathology. Till then, goodbye.